In this presentation, we will try and address some of the issues that affect patient care, patient insurances, and some of the things that I think are of concern to patients, as well as information they need to know prior to be seen by their physicians. It's not the most straightforward topic in medicine, but it basically brings about a lot of laying a lot of anxiety in those patients if they can be told ahead of time what is expected of them, what is expected of their insurance carrier, and what is the office's responsibility and also the patient's responsibility at the time when they present to a medical office for an evaluation. For instance, the concept that an insurance covers everything, a health insurance covers everything from soup to nuts is not the case. In fact, on the contrary, at the time of cost containment, at the time of economic recession, at the time when insurance carriers are cutting back and decreasing reimbursements to physicians, everyone is faced with a tight budget to manage a practice. Patients as a whole are probably faced with much more personal problems associated with visiting their doctors, and to be compounded by that to have additional bills when they were not even aware of it. So what I will try and do today is to try and elaborate a little bit on some of the insurance, some of the general procedures that we try to follow within the office to make sure that when you come to the office, at least you know what to expect. And try and be distinctive in terms of describing what some of the insurance carriers accept and they do not. In our medical practice in Richmond Hill, a patient presenting for the first time to the receptionist in the office either probably would have made a phone call to find out whether the office accepts a particular insurance. When that person presents to the waiting room in the reception area where there are already other patients who have been there before, sometimes they wonder, why am I waiting? Obviously, it's to try and verify that the first time we're seeing you, that the insurance is correct. Or maybe for that patient who has not been seen for a while, whether or not the insurance information is correct or you've changed your insurance. A lot of times patients, especially established patients, can make a difference to the office is by basically telling the receptionist when they sign in that they have a new insurance, the date and time they had that insurance, to please verify that it is active. There are also patients who've got local unions and other insurances which are seasonal, depends on the time they work. And those insurance kick in or kick out at different times depending on the number of hours that that patient puts in. Also patients who are probably on workers' compensation as well and other disabilities will lose their insurance and be covered on another insurance, and sometimes you're not aware of that at the time. So the time the patient presents, and let's take that first-time patient rather than the follow-up patient. That first-time patient is asked to fill up quite an extensive form, about 2 to 3 pages, saying who they are, their address, their phone number, and their social security number, and their insurance card to be verified. It's not a very easy and straightforward process to verify an insurance. Your name is there, but remember that there are also 100,000 other patients who are covered by the same insurance. They have a particular identification number. Sometimes when we actually read that number or write that number, we write the numbers incorrectly, and then you get that the patient is either denied or has insurance. Or when you try to bill for that insurance, if 1 or 2 of the numbers are out of order, especially when it's like over 10 or 12 digits long, then basically that insurance now kicks it back and says the patient is not covered. So at least at the very first time, at least make sure you present with a proper insurance card. We'll make sure that we do the proper billing for that particular insurance and make sure that the procedures are covered. Now, your expectation as a patient presenting with that insurance, let's take, for instance, you present with, let's say, GHI insurance. We verify that GHI card, and sometimes it's done it's an automated verification. You call a line, and automatically tells you when you put in the patient's number whether the patient is covered or not. That is very easy. Sometimes it is totally manual, in which you have to get someone who's sitting there at the desk to tell you whether or not that person is actually covered. And remember, most of these insurances are only open from 9 to 5. So it's very difficult to verify a patient's insurance coming at that time. My advice to you is, if you intend to be seen by a doctor for a non-emergency, is to at least make sure that they can verify your card before. I do not think they will ever bill for your insurance unless you're actually seen. You come into the office, you have to sign in your name. Obviously, it's a legal document. It's not only a legal document that has contractual agreement with your physician and yourself to establish a confidential agreement of your medical condition, but also in the event of the inadequate or inappropriate treatment, it can form the basis of a malpractice case, which in itself, it's a very serious issue. So your signature has to be there as verified that you were seen, and more importantly for the insurance carrier, to make sure you were the person who was seen at the time and not your brother who presented with your card. So there's a method you have to follow, and it is a method that's not a madness, but based on very, very important rules and regulations that has to be followed. That one, that basically your identification has to be produced. 2, you produce your insurance card. 3, you fill up the sheet that says the information that's required by the insurance carrier in order for your bills to be paid. Remember, it's not an automatic payment. Insurance these days, and I'll tell you quite frankly, use every method they possibly can in order to kick back claims to make sure that they waited for another 30 to 60 days before even paying. But it's the method in which the business, the healthcare industry seems to be running at this stage. Nothing is considered automatic. Now, if your information is not correct, whether you have a different name, then basically it is billed differently, and then that claim is then kicked back. Now, you now get a bill afterwards to say that you were not covered when you were covered because you did not supply the appropriate information. Also, in addition to that, your address has to be an up-to-date address, because the claim will now go back to you, because when an insurance company receives a claim from the physician's office, they send another one to the insured to find out whether or not they actually went to the doctor, that this is an appropriate bill, that the patient actually had the services performed, was this a work-related incident, or was it a no-fault injury, so they don't have to pay. Are there any other reasons that they want to use that they can actually do to prevent the payment of this bill? If your address is not correct, then the insurance carrier is not able to send that bill to you, and that bill remains in limbo. Now your account remains open. Our practice has not been in the habit of billing patients. In fact, I can think of all the 18 years I've been here, probably we've actually sent out not more than about 25 to 30 bills. But it's now become mandatory for physicians' offices to use more methods to actually help in collection, because it is such it's such a business that basically the carrying cost has become tremendously high, and the reimbursements have decreased all along. So in order to stay in business, it becomes much more important that you follow the rules and regulations much more stringently, if at times even at the discontent of patients who gets billed for services rendered. So it's important for us to address those letters that are sent from the insurance carrier saying the reason your bill has been denied is because your child is actually over age or they're a full-time student, to get that information back to the physician's office. In addition to that, it's your responsibility for taking care of your medical bills. You have an insurance which can take care of it, but it's still your personal responsibility. The insurance is meant to alleviate the cost of it. Sometimes your bill is covered 100%, but very, very few insurance are. But most physicians I know, especially in my office, we accept assignment. So it doesn't matter if the insurance pays $25, it pays $10, it pays $65. Basically, it is accepted. We do not go after the patients for addition. But you have to make sure at least even that small amount is actually taken care of. Those are some of the major problems we run into the front office. And I will tell you we can address some of the other issues to alleviate your concerns and your anxiety at the time when you are seen and when you receive bills that seem to be coming from the insurance carrier and also to be coming from the office. That is all for now. We'll continue our discussion on office procedures, insurances, insurance reimbursement, and how to alleviate patients' concerns and anxiety at the time of coming to the office. We mentioned the last time, my whole purpose of this discussion is trying to make it as clear as I possibly can, in an unbiased format as I possibly can, not in the event of trying to extract unnecessary income from you, but basically to make sure that if you understand the procedures that are followed within an office and the procedures that are followed by insurance carriers, you can know how to alleviate your anxiety and how to settle some of these problems. A lot of the times I find in my practice is that patients do not understand the procedure, and as such they're inundated with these questions that seems to bring about a false sense of either security that the insurance covers everything, or a false sense of distrust for the office, of their physician's office, that basically certain things are covered and certain things are not covered. And sometimes they get the impressions that they've got this card that says to them they can be allowed from soup to nuts, from a finger stick to an MRI, when in fact it is not so. And it takes a little bit of an education to realize, like everything else, insurance policies covers different things. And it depends on you as a patient to be educated as to what is covered for you and what is covered for you by that physician's office, in addition to that, what is covered for you and how frequently it's covered, and to also understand that the presentation of a card does not automatically make you distance yourself from the payment of that bill that is necessary. Whatever follow-up information the insurance carrier needs from you, whether to be supplying information that your child is over the age of 21, still covered because they're a full-time student, that your wife or husband does not have another insurance, that this x-ray was not done because of a work-related injury. These are all pertinent questions for the insurance company to ask. But sometimes I find in my practice the patients just disregard these letters. They become compounded over a period of time and nothing is done about it. Also, in addition to understand is that the various idiosyncrasies about different insurances. I mentioned to you over the last topic, when you come to the office to present the correct information in terms of identifying who you are. Because remember, you're using a card for an insurance to bill a doctor who is actually on their panel, and basically you have to be asked the question at the very front what type of insurance you have. Now let's talk briefly about what insurances are and what some of them will cover. For want of not being prejudicial in terms of what I'm going to be saying, I will just put it broadly in terms of some insurances and what they take and what they do not cover. For instance, the gold standard that we use is always Medicare because it's a government insurance. Medicaid per se does not cover many procedures within a doctor's office. In fact, very few, if any. It covers the office visits, but the reimbursement is extremely small, not making it cost effective for most physicians to actually be part of Medicaid. What they're part of is sometimes Medicaid HMO plans, which obviously reimburses for the patient to be seen, but a lot of time the procedures that are actually approved are not to be performed in a doctor's office. Medicare, on the other hand, is now an open insurance, which basically allows, and is obviously for the patient over the age of 65, or that patient who is on some permanent disability, for whether psychiatric illness, permanent disability from a physical illness, etc. That it covers most procedures. And when I talk about procedures, I'm basically saying it covers the office visit, it can cover an X-ray, it can cover an EKG, it can cover an echocardiogram if that patient is hypertensive, diabetic, high cholesterol, or does have another cardiac condition that makes them have shortness of breath or necessitate having that echocardiogram done. Also, the patient who's presenting with abdominal pain or evidence of a distended abdomen with a possibility of organomegaly, enlargement of the organs, whether the liver, the spleen, the kidney, the gallbladder, etc., can have a sonogram done. The patient presenting with obstructive uropathy, unable to pass urine, can definitely have a pelvic sonogram, differentiate the size and state of the prostate gland or the urinary bladder in a female to make sure that there's no evidence of an enlargement of the uterus, etc. So Medicare insurance will cover for that. For a case of an MRI, yes, you need to make sure, because it's such an expensive test, to make sure that it is going to be covered. But more often or not, it is covered by Medicare. And obviously, we'll ask for a letter of medical necessity to say that it was indicated. Other insurance carriers that we commonly see that will have issues in terms of covering, let's say, for instance, Blue Cross Blue Shield will cover for maybe most of the things to do with office visit, blood tests, an X-ray when needed, a sonogram for the abdomen in the clinician's office, an echocardiogram by a cardiologist only, and basic for MRIs to have verifications done. These are not automatic things that you can walk into the doctor's office and say, I've got Blue Cross Blue Shield and I want to have an MRI. It has to go through a procedure. Doctor, did you treat this patient for pain in the hip? If so, why do you think they need an MRI? Well, the pain is not getting better. I've used so many medications. The x-ray finding is normal. The patient is getting worse. And basically, I need to be further elucidate whether or not this is really soft tissue injury or evidence of bony injury or evidence of ligament tear. So you have to give them a letter of medical necessity. Why I'm telling you this is that basically when the patient is, when you present as a patient and you say, I demand having an MRI because I have this particular card, it doesn't necessarily follow that your card entitles you to this. It means that the physicians need to make a clinical evaluation and decide whether or not he can actually convince the insurance carrier that his $1,500 test or $1,200 for an MRI is actually indicated. Not because you're complaining of the pain, but it's medically necessary to differentiate whether this pain is just a bony origin or ligament tear. And if so, when you get the MRI finding, is that MRI finding going to be beneficial for further treatment? So a lot of times, especially insurance carriers are also faced with cost containment. So when they're faced with cost containment, they will deny you the payment of that bill. Then it's going to become your responsibility to pay for that expensive study. So at all times, at least be willing enough to listen to your clinician. They're doing this on a daily basis. They also know what different insurances cover and what they do not. Let's say, for instance, a big insurance like GHI, very good insurance, but pays very, very little. Here again, your cost of your visits are covered very, very small amounts. $25, $35, and you have a co-payment, and I'll talk about co-payments. Co-payment is that amount of money that should be paid at the time you visit. Let's say the insurance reimburses $35, and your co-payment is $20. If you do not pay that $20, the office visit will be $15. It does take a physician's office much more than $15 to bring in a single patient on a daily basis. When you think about the expenses for both malpractice insurance, which runs over $50,000 per physician in the state of New York, and for us who've been in practice for a while longer, it is even more than that. The cost for Department of Health maintenance fees, the cost of keeping your building open, the cost of staff, etc. You can tell persons who, when you actually run your own practice, that 30 to 40% of your income received is actually spent on running that office. So it's not as if it's a lucrative game anymore, but most of us who've been in practice understand that this is the only thing we know how to do. And having spent your life doing it, it's not easy to give it up. All you can do is to try and tighten the loose ends of it and make sure you can run an efficient, effective business so you can actively serve the people who've been good enough to you. And it's becoming increasingly common for physicians' office to close. In fact, I've got 3 friends in Long Island who have closed their office within the last year, and they had lucrative practices. They had good practices in terms of patients. Lucrative for me means when you see patients. Lucrative doesn't mean the money aspect. The tightened aspect of the practice to make it cost effective, that you can still open your doors to accommodate those who actually made your life a little bit easier when it was pre the days when we're going through these recessions and the tightening of the insurance industries. Then we're faced with issues now that we're not able to keep our offices open. Now we have to relocate, and those patients who are dependent on us for a service to be there for them now have to go elsewhere. Not only is that an important thing for them, they lose contact with a physician who they were comfortable with. They have lost contact with that person who has been seeing them for the last 5 to 10, 15 years, whatever. They felt comfortable with that person. They felt comfortable with the environment. And now that is lost. Now they need to start a new relationship with another organization. In starting a different relationship, you're subject to different rules. Not only does it bring about an anxiety in a patient when they go through these changes, they wonder, what else can we do now? What insurances are different? What other things are going to be changing on us? Now, in addition to the fact that if some offices are open later, now they have to change their work hours. They miss hours at work. So it's a lot of things that are associated with insurances, office practices, that it's open to the patient and the physicians. The physicians need to educate the patients. The patients need to make the time to understand what it's about. It's also about medical treatment, but it's also, in addition to that, it's also a business that unless it is viable, that pays for its bills, it will close eventually. As most hospitals, St. Vincent, for example, Catholic Medical Center, for example. Those are organizations within our own community that had to be closed because of fiscal deficits. Can we afford that we can just approach the practice of medicine as if it's a nonchalant approach to do everything and we can? No, it has to be approached in the format of a business without losing sight that the most important person there is still the patient. Thank you. I don't have to remind you how important healthcare reform has been, so much so that President Barack Obama made it one of the more famous fights he had with Congress and the House of Representatives in terms of putting it as one of the chief things on his agenda, even with us going through one of the steepest recessions for many, many years. So important was the cost factor involved and the politics involved in the healthcare reform, that it shows how influential the healthcare insurance companies are, the health insurance companies are, and what effect they have on the governing bodies, the state Senate, and also the House of Representatives. It makes us wonder in terms of how much lobbying power and how much more money they have to actually make sure that they can get the largest profits. But it's also their business to make sure that they run an effective business to make money for themselves. But in so doing, they've also put a tremendous amount of pressure on the local physicians and the smaller physician practices and also the smaller hospitals. We only have to be reminded of the cost cuts what it created for us in our little community in terms of the closure of Mary Immaculate Hospital in St. John's and the loss of those beds, the loss of treatment for those patients in those particular areas. So to think about it as this massive, the physician's office being not the place in which a patient should be treated friendly, is an oxymoron. In fact, the physician's office, the local physician's office, and the patient should be acting in close contact to make sure that the patient does not get an unnecessary bill, and the patient should be acting in an interest to make sure that that little physician's office is being paid for the services given. For as often as we sometimes hate the offices in which we visit, remember those are probably the reason we go there is because it was the most convenient place to where we live. It was also the place that was open to us when we finish our work. It was also the place that accepted the treatment of our children when we could not afford to bring them ourselves and we had another party brought them to the office to be treated. It was also the place that actually gave you treatment without even knowing that your insurance carrier was going to be paid. Remember, this is the cost of running a business, is that sometimes you put out before you even receive. It's also the office that writes the additional letter to assist you to cope with your personal problems that you sometimes have at home or at school in managing and keeping your family. It's also the same physician's office that at times would have extended to the school a letter to say that your child needs to be in school for an additional hour or two so that you can accommodate yourself at work. So your local physician's office, and albeit I will say definitely for my office in Richmond Hill, we've been backwards in terms of assisting our community. And at times you feel that the unnecessary remarks that you get sometimes are totally unwarranted. Putting that all aside, there's a responsibility that we owe ourselves and our families when we present to the doctor's office. It's to want to make sure that we're there for a legitimate cause and that cause is being addressed. Also, in addition to that, is that there's a cost for running a business. And as such, that cost can only be manifested in you providing the correct insurance information, the proper billing procedures followed, the proper procedures that are mandated by the health insurance laws, which says a patient needs to sign for their services and they also need to be billed for their services. There are two things that sometimes give a little bit of a problem in terms of our particular community in Richmond Hill. When there's a deductible is that amount of money that needs to be paid before your insurance becomes viable. Let's say your deductible is $100, then basically you have to pay $100 for the first time you visit any healthcare provider, whether it be the hospital or another doctor's office, a dental office, etc. It is that amount of money that is mandated to be paid. Now, some patients come in with a deductible of $3,000. There is no way that you could effectively help that patient to meet that deductible. The reason behind it, $3,000 is a mammoth amount of bills to be produced. There's no way you can actually, that patient needs to make sure that when you're actually asking for health insurance, make sure that your deductible is at least consistent with the number of times you expect to be seen by the doctor's office. If you're being seen in a hospital for chemotherapy or for long-term treatment, maybe $3,000 is not a lot of a deductible. But for a patient coming to a doctor's office, when you're expected to spend for the entire year probably about $1,000 to $1,500, a $3,000 deductible will never be met. So sometimes when you look at the deductible, please make sure it's consistent with your disease process. If it's hypertension, diabetes, high cholesterol, where you need to make 12 or 14 visits to the doctor's office per year, you cannot take a deductible that's high because your bills will never be covered. By the time the end of the year meets, your deductible kicks in again for the next calendar year. So understand what a deductible, it's very, very similar to our car insurance deductible. If we get into an accident, we have a $1,500 deductible that has to be paid before the car can be repaired. So it's the same thing that applies to health insurance. Now let's talk about co-payments. Co-payment is that amount of money that needs to be paid every time you present yourself to the doctor's office. It's that amount of money that will be deducted from the amount of money paid for the office visit. Let's say, for instance, your office visit for your insurance carrier pays $40 and your deductible is $15. You should pay that $15 at the time to make sure that the office visit is going to be paid. If you do not, just imagine the office visit is going to be paid $40, your deductible is $15. So for that office visit, the physician's office, if it gets paid on time, is $25. That is in no way feasible to run an office and pay physicians elaborate amounts of money and pay office staff also enormous amounts of money and keep your office open. So to understand that a co-payment is not supposed to be mandatory, at times we can understand that if in fact because of economic circumstance, we can't afford to pay that $15. But it needs to be documented. Patient is unable to pay it because of economic reasons. Because if you do not pay the co-payment, it's also seen as an inducement by the insurance carrier for that person, that office, to be seeing patients without paying the deductible. So at times it's a two-edged sword. The physician at the office, the physician wants to be kind, especially the one who owns the office, and say, well, can we forgive that patient for the deductible, even though it will cost the office that amount of money that basically it's not going to cover even the cost of the patient being seen. The patient comes here, and so does their family. And the goodwill brought by that patient cannot be counted in terms of $15. But it's also insurance policy that says to us, the insurance body, that basically it's mandatory to collect co-payments from all patients, or unless you can produce a reason, a legitimate, valid reason why that patient cannot pay that co-payment. So the deductible is an issue, and try and keep that deductible as low as you possibly can. The co-payments, try and make sure you make at least some of the co-payments. Mandatory for me to insist that all co-payments be paid, but I cannot control the economic situation and what most patients are facing at this point in time. We can try at all times to be as humane as possible to understand the issues at hand, but also in addition to that, the officers also faced with following the guidelines set by the healthcare industry and the insurance reform. And sometimes you course as a physician as to whether or not a physician and the owner of a practice as to whether or not you're able to keep both ends running at the same time. But I'm also insisting that you can also try and understand the physician sides of the practice as well. That is all for now. Thank you. We'll continue our discussion in terms of office procedures, insurance carriers, and the different procedures that are covered in a doctor's office. Patients sitting in a waiting room who basically see other patients come in can sometimes be a little bit annoyed by that, but sometimes those are patients who are being seen for workers' comp on no fault having therapy, who basically have their cases established. A patient may be called in ahead of you even though you signed in before them, especially if their insurance was recently verified and that patient only has to come in for a blood test result. In the event where insurance verification is needed, obviously you need to get in contact with the insurance carrier and make sure that that insurance is validated, or else you will be billed for the services because the insurance will deny it based on you not being eligible at the time. So falling office procedures sometimes can be a little bit annoying to the patient because they're not aware of what's taking place. And sometimes we as physicians, we do not educate our office staff enough to explain to patients everything. Sometimes in running a little bit of a busy practice, it becomes a difficult scenario to explain everything at the same time, especially when it gets busy. But it's also important for us to try and make sure that our patients remain calm and not exacerbate their own hypertension and their own cardiac status based on a simple fact that we're making it unnecessarily hard for them by not explaining. That aspect, I do apologize if it does emanate from my office. In terms of some insurances, obviously there are things that are covered and some things that are not. Covered means that the insurance will pay for it if done by that doctor's office, or if not, they will designate another place for that study to be done. Some insurances that covers most of the stuff to be done in doctor's office, like family physician's office, internal medicine, etc., like Medicare, United Healthcare, Empire Blue Cross Blue Shield. Blue Cross Blue Shield will cover things done cardiac in a general physician's office, internal medicine, or family practice. Other insurances like Oxford, which is now part of United Healthcare, will only cover an EKG to be done in a doctor's office. They will not cover for any further cardiac evaluation. However, they do assign cardiac evaluation to be done by other physicians. So getting a referral is not a difficult thing once you can establish that a patient needs to be seen by the cardiologist, either for an abnormal EKG, exacerbation of hypertension, or even the gamut of diseases that we tend to suffer with, which is the high cholesterol, the diabetes, the hypertension, premature heart disease, obesity, etc. Those are easy things to get and easy things to validate. And most of the insurances are very, very knowing fully well what the medical legal responsibility of denying are obviously intent on following through when a physician, especially when a physician is not being excessive in terms of ordering expensive procedures to be done, or seem to be in collaboration with other industries in making sure that all the expensive things are being done. Things like MRIs can be approved to be done, but obviously needs to have a letter sent or discussion with the insurance carrier as to the necessity of having that procedure. And here again, I told you the cost of an MRI. So sometimes the physician or the physician staff gets on the phone, explaining the need for that procedure to be done, the need for that procedure to be sent for the patient to have a cardiac procedure, the need to have a colonoscopy, especially when the patient's age does not meet that limit of over 50 years, the need for having a neurologic procedure if in fact you're having numbness of the legs that's persisting, associated with increasing weakness, and you're basically faced with a neurologic problem. But here again, it is not the easiest thing. It takes time on both the part of the physician and the physician staff to get referrals done. All I'm asking for is, in the event of things being necessary, the staff at all times, the office at all times, once I'm in charge, will make it a priority to get it done. The issue at hand is that it's not an automatic thing. Neither are we in charge of the process. It is a due process that you have to start by making that call. You make that call, you tell that person who's answering, and it may very well be an entry-level person who's taking the information. Now, that information now gets to either the nurse in charge, who then makes a decision. Is this a clear-cut case for them doing this procedure? If he or she is not aware that this is a clear-cut reason, it's not fall within the guidelines of doing a procedure, of saying, let's say, for a patient with a pain in the lower back, with sciatica, is not an indication for getting an MRI. But sciatica now associated with losing control of the leg, yes, that's another problem. Sciatic control with loss of muscle bulk in the leg, that's another problem. That in fact will fall in the guidelines of getting these studies done. Then if that is not approved by the nurse, the supervising nurse, then it takes it up to the medical director, the physician, who then has to make a decision. Just imagine if it has to go through this process, it's going to be a week, 2 weeks before it's even approved. Now, if you say, well, send me to the hospital, then the hospital is faced with the same issues. And you may go there and you said, yes, I referred you to the hospital, but they kept me in the emergency room. They did nothing for me because no one is able to get a verification done at the time. So it's not a process that's automatic. It's not a process that's taken for granted. It's sometimes done in the best interest of the patient at all times. And for the 15 plus years that I've been here, at all times I've instructed my staff, do what you have to do in the interest of the patient. Because at all times, that is what is the right thing to do. And it's the only thing we'll ever want to do. The issue is that we do not control the process. We do not control the insurance carriers, what they approve. At the same time, we're faced with other issues that basically they will sometimes approve of it, and then they still end up billing you. At that point in time, we have a verification number that at least we can defend it. So at times I ask for patience in terms of patients to understand that it does take time for things to get done. There's some insurances for GHI will cover, let's say GHI for instance, for $11.99, will cover an EKG and a blood test, but that's it. They will not cover for anything else within a doctor's office. But those are their guidelines. It doesn't mean they're bad. It means that basically that's their policy. So for anything else to be done, it has to be sent out to be done. And a lot of patients say, well, I like to come to your office because I could do everything here. No, it's everything if it's permissible. Everything if it's going to be reimbursable to you and you're not going to be billed for it. Sometimes we do things out of necessity because we need a result now, and the office carries the cost of doing that. But it's a person-to-person basis, and it depends on the physician who's in charge to make that judgment call, whether or not the office can afford it. Sometimes you try and do an x-ray when it's not even permissible to get it done, knowing fully well you're not going to be paid, because that patient has brought enough goodwill to your office that you don't think an x-ray will make you bankrupt. But it doesn't mean that it will be taken care of. And sometimes here again, you try and extend yourself as much as you can. But a lot of times the instructions that are coming is basically very forthwith in terms of what your insurance carrier will pay for and what it will not pay for. A lot of the HMOs and Medicaids will not pay for anything done in the doctor's office. Sometimes you need to get authorization to even get an office visit, sometimes to get an EKG done. But that's the nature of the insurance business. I'm not saying it is bad. I'm not saying it's basically different. I'm just saying it is a procedure that we need to follow. The same procedure we need to follow in terms of caring for patients, examination of patients. The same procedures are strictly mandated by the state of New York, both by the insurance industry and the healthcare industry, as to exactly what is permissible, exactly what can be done, exactly what our responsibilities are. And as patients, we do have our responsibilities. As physicians, we have our responsibilities. And in the event we fail to live up to our responsibilities, there are enough trial attorneys out there who are basically looking for physicians. The issue about that, it's a very tightly regulated industry, and at all times I'm asking you to observe the rules and regulations of the office. Try and at least assist us with giving you a proper phone number, giving you a proper insurance card, giving an updated insurance card, giving any change of address, giving any change of marital status, giving any change of if an insurance is given to you now as opposed to being on your husband or wife's insurance. If your child is being seen over the age of 18 and that insurance doesn't cover, is the child a full-time student? Bring the registration card from the university or the college that says it's a full-time student. All of these things can make life so much easier in the physician's office. It can make life so much easier for the personnel at the front of the office who basically are faced on a day-to-day basis, inundated with numerous questions, especially at this point in time when everything is so strictly regulated. The amount of paperwork that I've seen over the last couple of years is almost twice to 3 times as much as when I probably started practice 25 years ago. So even though we would like to try and provide as much services as we possibly can, I also want the patients to understand that basically there's some form of limitations within all insurance carriers. We want to stick within the rules and regulations of an industry that is much bigger, much broader in terms of its influence, much more effective in us cooperating with them than aligning ourselves on the opposite side of the fence with them. I'm asking you all at all times to be respectful of the rules and regulations of the healthcare industry and of the Department of Health as well. Thank you. Continue our discussion on the verification of insurance. Having verified that insurance is now it's viable, The patient is now instructed as to basically what the insurance covers and what it does not cover. At the time of signing in into the billing sheet, basically to be seen. Obviously, the receptionist / medical assistant / nursing assistant will ask the patient at the time of the encounter exactly what they're being seen for, not necessarily to give them all the medical information. I'm being seen for my blood pressure, I'm being seen for my chest pain, I'm being seen for my headaches, I'm being seen for my dysfunctional uterine bleeding, I'm being seen for a urinary problem, or I'm just here for a physical checkup by the doctor, or I'm here for a referral because of persistent pain in my knees and I need to have it further evaluated, etc. And these are some of the reasons that you just barely say at the very front of the office. You do not need to be more elaborate than that in terms of discussing your medical problems. Or I'm here for refill of medications that I will discuss with the doctor. But she has a duty to perform to make sure that she's documenting that you are right, signing your name, you are who you are. She has verified insurance and make sure, because it is insurance fraud if you do present with a wrong card. And it doesn't deem you, the person, it deems the physician's office as being the one who's fraudulent in this case. Now, having done and everything is done properly and you basically sign in to be seen by the physician, it may be protocol of the office for, let's say, a hypertensive patient presenting for the first time for evaluation for renewal of the medication to have an EKG. It is office policy and procedures that that should be done. Sometimes the patient will say, well, I don't need anything to be done, but it's up to the physician to say, if I am going to be prescribing your medication, which is a beta blocker, to slow your heart, let me at least know what your heart rate and rhythm is before I decide to prescribe that medication. And usually in the interest of time, you will say to your office staff at the very front, if you see a patient for hypertension who wants refill of their medication, please make sure you get me an EKG, the blood pressure, the height and the weight, before I see that patient. If they do not have a recent blood test, I need to see that blood test. If not, I will need to repeat it, because there's some medications like diuretics that will cause you to urinate and pass out your electrolytes and can actually decrease the potassium levels. So sometimes before you prescribe medication, sometimes patients ask for expensive medications too, which insurance carrier asks you, why are you prescribing this when it's not even necessary? For instance, treatment of high blood pressure with a patient with albumin in the urine necessitate having an ARB or an ACE inhibitor. These are expensive medications, and insurance carrier expects you to be able to justify the reason as to why these expensive medications. For instance, for the control of diabetes, providing a medication like Actos, which is extremely expensive, or prescribing a medication which is hyphenated with a high cholesterol medication, can sometimes cost the insurance carrier twice as much money. So they want to find out the reason as to why you are actually prescribing it. Is there a monetary benefit on your part for prescribing it? So a lot of times when you're asking for stuff to be done, it is in the interest of trying to try also to be on the insurance side for cost containment. Because if we're going to be able to survive this crisis, and we'll be able to be in a position to continue having the coverage we're having, then we all have to be on the same page and trying to save at the same time while trying to keep the services that we have. Now that patient is seen, everything went well. The patient had an EKG or whatever studies was involved, and basically the patient's ready to leave, had their prescriptions and everything else, and we're now giving a follow-up appointment to be seen by the doctor. It is mandatory that a patient, once been seen in an office, be given a follow-up appointment. Whether or not you decide that you want to be followed up is irrelevant. It is in the interest of the physician having prescribed a medication. It is now your sole responsibility to monitor that patient's performance on that medication. It is not the drug company. It is not the pharmacy. It is not the family. It is the physician who has put his signature as being the licensed personnel who has got that foremost responsibility to follow you for any side effects to that medication, to whatever procedures that he's advised. It is his or her sole responsibility. He is the one or she is the one that carries that license. So all physicians, it is mandatory. It's also covering your back to make sure that you give the patient an appointment to be followed up. And you need to know why you're following up. If I'm giving you a high blood pressure tablet and it's not controlling your pressure and it's causing your heart to race, then I should be informed about that. If I'm giving you an antibiotic and you start to develop an allergic reaction and you start to have difficulty breathing I should be informed about that, because that's basically the premise on which medicine is practiced, that if I give you anything, it should not be doing you any harm. It should be doing you good, and if in the event of a harm, then I should be contacted. So at all times, we will give you a follow-up appointment. If you do not get one, ask for one at the front. Also, in addition to that, any procedure that is done should be discussed with you by the physician. Any blood test that's done, it's the physician's responsibility to bring you back and discuss that results. It is not convenient to discuss it over the phone, because a lot of times we're not quite sure who we're speaking to. It's not even proper to document a telephone conversation about you having your sugar levels way above twice time normal, and I'm not telling you what to do. I cannot even document it on the phone. If I have you in front of me, I can tell you exactly what you need to do to bring down that sugar level. And if it does not come down, what are the things we'll do to bring it down? It's also important for that visit that you educate the rest of the family, whether it be your wife, your husband, or your kid, in order to make sure that you can follow through with your diet for your hypertension, your diabetes, your high cholesterol, and know the risk factors you face for coronary artery disease. Or that belly pain that you're having is not just a peptic ulcer disease, it's something more sinister, and we'll need to get a colonoscopy done. And it's not for you to decide when you're going to have the colonoscopy done. It's for us to make sure you get it done as fast as you possibly can. Because in the event you have something like a colonic lesion that turns out to be a cancer, obviously it becomes a medical legal responsibility at that time to diagnose it. And if the diagnosis, the failure to diagnose, this becomes the responsibility not of the patient, but of the physician. So there is a reason for patients to be followed up. Haven't seen a patient, you just do not leave them there, hang them out on a medication, and tell them come back when you feel like. It's mandatory, having prescribed it, to say, let me follow you back in a particular period of time. For instance, if an antibiotic is given, maybe in about 4 to 5 days, to make sure that you're getting better, and make sure I can document either by laboratory or clinical finding that you are better. Or if I give you a high blood pressure tablet and you've not had it for a while, or you've never had it before, is to make sure there's no abnormal EKG changes that is making you worse, or is going to precipitate a cardiac event that is going to make you go to the hospital for something even worse than what you came for. So it's also important that we know, as patients that haven't been seen by the facility, you have an automatic appointment to come back for re-evaluation. A lot of patients will say sometimes, and not a lot, but few, why do you need to see me again? The issue about that is basically having put a patient on a medication, you as the physician, it becomes your responsibility to monitor that patient on the medication, because the patient will not be the one who is faced with a litigation issue in the event of an adverse outcome from whatever you've done. So it is of medical legal significance that this is actually done. In addition to that, it's also good practice that you're able to follow up with that patient to see the improvement of a patient. There's nothing better to see somebody who feels unwell, feeling lethargic, feeling they have chest pains, feeling as if they cannot work, feeling as if they have the worst burdens on their shoulders, and you see them 5 to 6 days after on top of the world feeling as good as you possibly can. It is nothing that drives your day much more positively than to see that effect. To see that person with a severe exacerbation of hypertension complaining of neck pains and headaches and dizziness and coming off work or not being able to work to 2 to 3 days, and now seeing that patient thereafter, a week after, with the blood pressure medicine, with the heart rate control, with the blood pressure control, telling you that they're having a blast of a day. It is the only thing that drives you as a clinician if you're interested in how the patient is improving. If that patient is getting worse, then obviously you have a much more important function here again, not only to fester your own ego and to make yourself feel good, but to act on behalf of that patient who is having persistence of that symptom. So it becomes a mandatory thing for us to be able to evaluate our patients and not rely on them to tell you, oh, I felt better, so I never came back. That is inexcusable in terms of the standards acceptable by the healthcare industry and the Hippocratic Law. Thank you. In reviewing the billing process, it goes by stages. Patient is seen in the reception area, gives their card to the receptionist who verifies the insurance. The insurance is verified as being in place. The patient is seen. Whatever procedures are permissible by the insurance carrier The patient will be told that's acceptable to be done, but other procedures are not permissible. The patient will also be told that it cannot be done by our facility, but we need to refer you to somewhere else to have that done, if in fact it's deemed necessary by the physician. Now that patient is seen, they sign into a billing sheet, which then goes, when the patients leave the office, that billing sheet goes to the biller in the practice, to the billing company. The billing company uses information on the insurance card plus the patient's date of birth, the patient's correct name, their date of birth, the relationship to the insured, and the type of insurance plus the insurance card number. It's very important we get that number correct and the date of birth of the patient, especially in our community, in which, especially I've seen with common names, common patients' name of Guyanese descent, that are especially Singhs, Mohammeds, Khans, etc., that are very, very common surnames, Prasads, that sometimes you get the date of birth mixed up, and patients with 2 or 3 different names, patients with similar names, get billed for different insurance carriers. We try to make sure that that is not something that happens too frequently, but it has happened in the past, and sometimes it does create a very uncomfortable situation within an office. That bill is now sent out to the insurance carrier by electronically, or can be sent out by manual mail. Most insurance carriers today actually prefer electronic transmission of bills, and in fact have made it mandatory for some insurances that you cannot submit manual bills anymore. So that information gets to the insurance company within 48 hours. Now, sometimes even before the patient is feeling better, the insurance company has received that information because it's sent electronically. The patient now sees the bills, and they can actually send it back to the patient's address, and that's why it's important to have the correct address to find out if you are actually seen by the doctor's office. And sometimes there are 2 things that creates a little bit of anxiety in the patient, sometimes a lot of anxiety in the patient. For instance, having received now an EOB, an explanation of benefit. You've seen the patient, so you write, I've seen you for an office visit. An office visit is billed as, let's say for codes, CPT codes, let's say 99214. Let's say the average cost for a 99214 visit by a board-certified family physician or board-certified internal medicine is basically, let's say it's $200. That's what's billed, because that's what is part of the CPT code that is billable for a physician practicing in this zip code can be billed for. I can bet your bottom dollar there's no insurance carrier today that ever pays $200 for a physician visit. In fact, I'll tell you quite frankly, the norm is probably closer to $60 to $80. And out of that, you have to minus your copayment. So just imagine if your copayment was $30, that visit is worth $60. Your initial physician's evaluation is $30, probably much more. It cost me much more to get, when I used to have a lot of hair, to get a haircut than it is to visit a physician. So much so it is affecting us in terms of how these things are done. So the office visit, when the patient receives it, they say that basically the office visit is $200. $200 was billed because it's acceptable. That is what the norm for that location is, for the zip code, and that's created by the insurance company. Let's say you had an EKG that was done. An EKG has a CPT code, say 9300. That is billed, let's say it's billed for $60. The insurance carrier might pay $15, maybe pay $20 for that procedure to be done. So on one side of it, you see what's billable. The other side is you see what's paid by an insurance company. What I'm asking you to do is to understand the one that's billable is not what's created by that office. It's what's created by the healthcare industry that regulates the payments given to physicians in this zip code. What is done in the right-hand column, and a lot of times when a patient brings an EOB to the office, which is an explanation of benefit, it shows on the right-hand column, and when you take the right-hand column all the way down, 0. It might show on the left-hand column, $200 bill for an office visit, $60 for an EKG, a chest x-ray $75, and you might find out that at the end of that, oh, I've got a $400 bill, and then you move to the right-hand column, out of that, $70 totally paid. And I'm into the office, why did you bill the insurance company $400? It is billed because that is part of a computerized information that is there. If you lower that, then you lower the cost of the other physicians in the area, and not only that, it is not the right thing to do. Whatever is customary and norm for your location is given to you by the insurance carrier. Whatever they decide to pay you If you accept assignment of benefit, you cannot bill that patient for extra. Quite frankly, I'll tell you, in my practice over the last 18 years at Richmond Hill, I have not billed a patient for an additional amount of money, even if it does. It's not acceptance of benefits. But you accept whatever is paid by the insurance carrier. Because for me, the most important thing was the patient and not what the insurance carrier was paying. I prefer to have an extra patient than to have an extra insurance. So at all times, it meant that looking on the side of the patient. But when the patient brings in that information and also brings it in with an attitude that says to you, doctor, you billed for $400 and you only saw me for 20 minutes. I billed you for $400 because that's what's mandated by the state. $200 for the office visit, the x-ray for what, $75 and whatever additional cost. But whatever they paid for was $75. So look at the other side of it before you become irate and start to make remarks. Because bottom line it is, we're all going to be sensitive to anything that has to do with money. And also, in addition to that, the office staff doesn't need to be inundated with phone calls that criticizes them, or criticizes the physician, or criticizes the times, especially if you're not feeling better. That part of it I hate most of all. If you have to pay and you're not feeling better, especially if you're misinterpreting what you had to pay. So sometimes when you want to have an explanation of benefit discussed with you, bring it to the office. Let us at least have a look at it so we can tell you this is what was paid, this was not paid, and this is actually what the insurance company is relying on. Sometimes they just send you a bill to make sure that you respond to it that yes, you were seen by the doctor's office. Sometimes they send you a bill from the lab. A laboratory blood test sometimes is billed for something close to $500, $600. I don't run a lab. I don't have a lab. I don't have an interest in a lab. But you come here for evaluation of your high cholesterol, your diabetes, your risk factor for heart disease, your prostate cancer, your cancer of the ovary, the dysfunctional uterine bleed. I've got to do the proper tests. Sometimes those tests cost about $700 to $800. And then you get a bill from the lab and you think it's coming from Dr. Baldeo's office. It's not. It's coming from the lab. So then you look into that bill and then you see where it's coming from. But what you can do ahead of time is just look and see where it's coming from. Call them and say, look, I have an insurance, and the insurance has to accept whatever the lab has to accept, whatever the insurance carrier is agreeing to pay. The same way at the doctor's office will use their own judgment in accepting, especially if you accept assignments, you have to accept what is being paid. You cannot ask the patient to pay additional money. The same thing about the patient have a responsibility. If you've been sent an information by an insurance carrier questioning whether or not this is what information, whether or not you have an additional coverage or another coverage, or this is your primary or your secondary, please send back that information to them. Because if you do not, it slows up the process and it retards the entire process, and then you become more and more inundated with extra bills at all times. So my thing about it, just act on it once you receive it, or bring it to the office. Let's at least reevaluate it for you. In medical practice, there are lots of commonly used tools that the doctors and nurses use to evaluate patients. In my years of practicing medicine, I've learned that possibly the chest x-ray is one of the most underutilized tools in the practice of medicine, or probably one of the most unappreciated tools in the practice of medicine. We have all come to expect, those of us who have transcended time, that the x-ray was available to us in our home countries and much more available to us in advanced countries than the sonogram using ultrasound waves to diagnose organomegaly within the chest and also within the abdomen. And then we got the CAT scan, the CT scan, and then the much more diagnostic and definitive diagnostic procedure like an MRI. But when we think about what the chest x-ray has been for a clinician, it is one of probably the most useful and widely used tools in the practice of medicine. And even as it was for me 25 years ago when I first started medicine, I still think it is as relevant today as a tool in the diagnosis and treatment of clinical condition, even if it is only to be able to rule out diseases that are present so that we can move on with treatment and then reevaluate at a later date if we find that it's not responding to treatment. If you look at this diagram, we can see what a classic chest x-ray looked like, and eventually I'll go through the chest x-ray with the thoracic spine, the lung fields, the rib cage, obviously a female with breast shadow, the evidence of the gut within the abdomen, you can see, the shoulder joint, the ribs. And I'll try and relate this to what takes place when we look at an X-ray. How do we actually, as clinicians, look at it in terms of if we're looking for the external structure in terms of the ribs, or if you're looking for internal structure, how it affects within the organs that the lungs, the heart itself. We also will try and look and see how it affects the infective processes that we get from things like bronchitis to pneumonia, bronchopneumonia, lobar pneumonia, etc. But when your clinician asks you for a chest X-ray, the most important thing for a female, especially for a female, is to make sure that we know. The radiation dose of an X-ray is extremely small. It's probably equivalent to what you will get in 10 days of minimal exposure to sunlight, even if it's 10 to 20 minutes per day. So the exposure is a very limited thing. What is important is that once you're not pregnant, it cannot cause damage to any organ system unless it's done repeatedly. And even if it's done repeatedly, the chances of regenerations are massive, and it's really not going to have any side effects. What is it that you basically associate with having a chest X-ray and the usefulness of it? It is one of the golden tools in medicine from the age of the neonate to geriatrics. I remember in neonatology waking up in the middle of the night after delivery to have a chest X-ray for a child. Usually at times we worry at that point in time whether or not there's meconium aspirate. That's the same product that happens when the child actually aspirates it and can give a pneumonia. Immediately when we find evidence of respiratory distress within a neonate, a chest X-ray is indicated. A chest X-ray is indicated at that time whether or not there's evidence of infection or obstruction within the airway. It's also done immediately afterwards when you put in an endotracheal tube to allow that neonate, that's that newborn baby, to breathe. So from the time of our birth, a chest X-ray for us as clinicians is one of the most useful tools. If we think about it as we go through childhood, blunt trauma to the chest in a child who's fallen, we want to rule out a rib fracture. Foreign body ingestion, we're looking at that child, did he actually swallow a coin? Here again, we go straight for the X-ray of the chest, the X-ray of the abdomen. As a young person growing up, undergoing sports injury to the chest. Also things like cardiac disease that occur within the pediatric age group. Things like congenital heart disease. You look at the X-ray finding, first of all, when if someone complains of shortness of breath or palpitations, an EKG comes back as normal, you get a chest X-ray. That chest X-ray will show whether or not there's any evidence of cardiomegaly, enlargement of the heart. It doesn't necessarily mean it's the only diagnosis, but it's the initial diagnostic tool that assists the clinicians right away to say, well, is there evidence of the left ventricle of this person, of this child, of this young adult who's presenting with shortness of breath? Does it show evidence of cardiomyopathy? Should I now proceed with having an echocardiogram to see what the ejection fraction or the amount of blood that's being pumped out of the heart is? Can I have an echocardiogram to see what the left ventricle is, the thickness of the left ventricle, for diagnosing problems like hypertrophic cardiomyopathy in a young athlete who's presenting with shortness of breath? The same indication we do for a young adult who comes in with persistent cough, cold, fever, which we've been treating as a bronchitis, and we're not quite sure whether or not that bronchitis has actually moved on to become a bronchopneumonia, a walking pneumonia, or is this now a lobar pneumonia that is going to necessitate infection? In the young person at risk for HIV, is this a pneumocystis pneumonia presenting at this stage? So throughout life itself, from neonate to the young adult, we all use the chest X-ray at different points in time to help in diagnosis. As we get older, we basically also use the chest X-ray sometimes much more frequently. In the nursing homes, chest X-rays are used routinely to basically for an elderly person presenting with shortness of breath. The diagnosis of congestive heart failure sometimes is made from a clinical diagnosis, but confirmed from a radiological diagnosis when we detect fluid under the lungs. So a chest X-ray, even though a very rudimentary tool and it's been in existence for a while, still for the clinician, the old and the young, still is a very, very useful tool, and it's probably one of the most underrated tools in the practice of medicine. That is all for now for chest X-rays for a while. Thank you. Having made the decision to have a chest X-ray and explain to the patient what is the procedure, for most of us who've had it, it's basically a no-brainer in terms of what is required. But for those patients who have never had a chest x-ray, it is very, very basic. The principle behind it is using radiation, an x-ray, which is similar to light radiation or ultraviolet x-ray radiation, to penetrate. It comes from a tube that produces the x-ray that goes through the body into a plate or a shield that's in front of it. So you have the film in front of you as you're standing and having the chest x-ray done, and the tube from the back about 6 feet to 4 feet away that's shooting a radiation through you. That radiation comes in a stream that comes like this from the source and comes and spreads out onto the film. So you're standing, your film is anterior to you, the radiation is coming from the back. The penetration of that radiation is going to be dependent on the tissue that's absorbing it. For instance, if we look and we see the x-ray of a rib will show as being white, which means the bone itself, because it's so dense, has absorbed that radiation. And that appears now white on the film, because basically most of that radiation is in the bone and the exposure to the film. Now, if that same x-ray radiation goes into the lung fields, which is now air, that will appear black in the case of a well-aerated lung. So the more radio-opaque something is, the more dense it is. So the principle behind this is very, very simple. The more dense a material is, the whiter it appears. So we expect our bones to appear white. So we shoot this radiation, the x-rays, which now goes through the body, hopefully through the organs we're looking at. Let's say, for instance, the lungs in this case, and then it penetrates into the lungs, and we pick it up on the film. Now, in the case of someone like, say, this is the heart shadow here, because the heart is a muscle, and the muscle absorbs less, but you can see the cardiac silhouette here. You can see the diaphragm here. You can see beneath that, this is the breast shadow, obviously absorbing enough of radiation because it's dense and tissue, and it's a younger person. Now we look at the bones of the thoracic spine as well. They're absorbing radiation, but the lung fields in itself are dark and black for well-aerated lungs. The cardiac silhouette, because of the heart shadow, here's where we can look at it and see whether the diameter of it is normal or it can be enlarged, especially if we're wondering whether or not this patient has developed cardiomegaly. In the case of bronchitis or bronchopneumonia, we look for evidence of basal atelectasis or evidence of consolidation, which means now instead of just being well-aerated dark lungs, we now have this whitish opacity, which says to us now it's not air alone, now it's air plus now the infective process which produces the secretions plus the bacterial consolidation of the lungs. Remember the process of an infection. What happens if we look at this diagram just basically for the lungs itself? For bronchitis, it's infection involving the bronchioles, or within this is the trachea, that's the bronchus, and the infection is within the bronchioles. Now in the case of a pneumonia, you can have a consolidation within, scattered infiltrates and consolidation within the lung parenchyma. In the case of a lobar pneumonia, when you have one of the lungs, each lung is divided. The right side of the lungs has 3 lobes, the left side of the lungs has 2 lobes. In a lobar pneumonia, what happens in that case is that the entire lobe of that lungs then collapses. When it collapses, what you tend to see is the well-aerated part can overexpand to fill the space that's collapsed, and the portion, let's say for instance, the lower lobe here is collapsed, or the middle lobe is collapsed here, then you have thickening of it because you get a wedge shape, now consolidated lungs. In the case of an infection in which there's no collapse, then you will have evidence of this appearing as a white opacity without over-aeration of the upper portions, but also in addition to that, you have the opacity that suggests to you, because it appears white, that it is definitely infected because now it's consolidated. All it means now, instead of being nice breathing lungs with air passing in and out, now what you have is evidence of consolidation or no hardened secretions within the lungs. And we're hoping that the antibiotics will treat it and get us back to where we were before, but it's going to take a lot of effort to re-expand that lungs. Now, when you repeat that x-ray, what you're looking for is that wedge section of the lungs that was collapsed or consolidated to make sure that has re-expanded. So those are the things you tend to follow with your x-ray in terms of if your doctor even advises you to have serial radiations. In preparing for an x-ray for that new patient, it's a simple instruction that make sure you're not pregnant. We will be exposing you to the radiation. Remove all metal objects you have on you. And basically, it's just exposing you can have a gong over you, obviously, and exposing the radiation from the back or to the side. If it's a standing plate, we can definitely make it very simple. And you stand up against the film. Or if you're lying down, then obviously you're lying on the plate and the X-ray radiation is just shooting downwards. Very, very simple process. Very, very simple principle behind it. But the benefits for us as patients and as clinicians is tremendous. That is all for now for chest X-ray and the procedures involved. In my private practice in Richmond Hill, chest X-rays are done on numerous occasions during the days for different indications. But one of the more common causes for doing an X-ray is for treatment of trauma and infection. Usually in a younger adult who comes in with pain over the chest wall either from playing a sports or a sports injury, or maybe blunt trauma, incidental blunt trauma to the chest wall with moderate to severe force, and trying to rule out a rib fracture. But in addition to that, we look upon the X-ray as being basically trying to see what it is that we're looking for, the clinician is looking for in the X-ray. So whether the reason for doing the X-ray is based on, let's say, trauma in the young adult, or an infection in either a child or an adult, whether or not it's a bronchitis, a pneumonia, whether or not it's just a normal finding of bronchiolitis, whether or not it's evidence of allergies and then you're having postnasal dripping, or in the case of the elderly person who presents with shortness of breath, whether or not that's related to congestive heart failure, or in the instance of having fever and chills, whether or not it's related to an infective process. For some of us who have been unfortunate enough to be involved in the habit of cigarette smoking for many years, obviously we always worry in terms of is there evidence of a lung cancer. I've seen recently, over the last maybe 3 to 4 weeks, one patient who presented with shortness of breath and had evidence of diffuse infiltrates throughout the lung fields, who now had metastatic lung CA. I'm not quite sure where the primary is, where the actual lesion started from, and that's what we're trying to investigate now. Albeit to say, at a case now that this gentleman is presenting for shortness of breath for almost about 2 years with mild form of hemoptysis, which is like just coughing up a little bit of blood, a chest X-ray actually showed diffuse metastatic disease, which means it had been there for a while, where the primary was, whether it was from the prostate, because now we started to have lung prostate CA, whether or not the primary was in prostate that then spread to the lungs itself, or the primary was one of the bones, because there is an osteophytic lesion for this particular patient as well. All I'm alluding to is that in this particular gentleman, had he had a chest X-ray done maybe a year or 2 ago, we may have been able to pick up 1 or 2 lesions within the lungs, which could be remedial to treatment, whether it be radiotherapy or chemotherapy. I'm not saying it could be, but it depended on if it were diagnosed earlier. At this stage, we're diagnosing of metastatic disease in which the entire lungs, if you look at it, you get these wide diffuse mottling over the entire lung. We did a CAT scan for it. It shows he has diffuse infiltrates throughout the lungs, and that is now spreading throughout. And this is a normal looking lungs, because basically it's nice and black, the air is coming right through. But in the case of lung cancer, you have these in diffuse infiltrative disease. He had evidence of these nodules throughout the entire lung. So in cases like these, the gamut of doing an X-ray, well, let's say the average patient who walks in would say, "Doctor, I'm having pain in the chest. I've been involved in some physical activity. I was doing a lot of heavy lifting, and I'm having pain localized over, say, the left second costochondral junction. Is the junction between the cartilage and the bone. Let's say it's this area here. Let's remove the muscles And let's say it's not to do with trauma, but this is heavy lifting. Obviously, over this area with it is a costochondral junction, something called Thread's disease. An X-ray will show, an X-ray done will show a normal finding. An EKG done at the time will show maybe if the person is healthy, will show nothing. Now you're going to have to treat it as basically a localized musculoskeletal phenomena and treat it as such. And reevaluate the patient if it gets worse once you've ruled out common conditions. In a case in which you have definite blunt trauma and you know that's causing the pain, you're going straight to the source and say the blunt trauma to the chest, let's say the muscle, or is it the bone? And your X-ray will say basically there's no evidence of a hairline fracture, and you can rule it out on the X-ray, especially if you're coning in just on finding that bony injury. And you can treat it for a soft tissue injury, evaluate it within 48 hours, and basically still be keeping within the normal practice of medicine without having to overtreat the patient with a non-steroidal anti-inflammatory, resting it, and moving on. The same thing for a woman who presents with breast pain. Sometimes it's localized to the chest wall, but if it's localized to the breast, obviously you will try and get your sonogram for the breast, examine the breast to make sure there's no lumps or bumps within the breast, because obviously for us, a lump in the breast is breast cancer until proven otherwise. Obviously, in a younger adult, we think of things like fibroadenoma, fibrocystic disease, and we always think in terms of the time of the period, the time when the pain comes on, what exacerbates the pain, what relieves the pain. And obviously, we try to make our diagnosis. But definite any evidence of a lump in the breast that produces pain, remember most cancers, or most lumps in the breast that are cancerous, are painless. So a painful lump is for a clinician, it is a nice diagnosis. It means that basically that patient is probably having an inflammatory process, could be fibrocystic disease, or could be a fibroadenoma that's undergoing changes. When it undergoes changes, degenerative changes, it is painful because of the inflammation it produces. Obviously, if the lump is there, it should be biopsied. It should have a sonogram to make sure it's not solid or cystic. A cystic lump needs to be aspirated. A solid lump needs to be biopsied. Biopsy meaning removing the lump and sending it for histopathology and waiting for the diagnosis to come back. In our elderly or more our young to middle-aged or middle-aged to elderly patients, obviously we'll try and get a mammogram, which is much more useful diagnostic tool in the female who doesn't have this dense breast tissue. And obviously it's going to make the diagnosis that evidence of calcification or evidence of irregularity within the breast itself, and obviously we'll try and biopsy it. But we can get a diagnosis even before biopsying it, especially if it looks cancerous. And obviously there are things that makes a lesion look cancerous. Obviously it has spicules, it has calcification, it's called tethering of the skin. Well, those are advanced stages, but at least at the same time, pain involving the chest wall itself in both males and females, whether due to trauma or inflammation, whether it involves the junction between the cartilage and the bone or the breast tissue itself. And men also understand breast cancer is also a disease of males. So if you find a lump in your breast, you're also advised to have it biopsied. That is all for now. Thank you. We will continue our discussion on the usefulness of chest x-rays, and I will try and relate the chest x-ray, how the x-ray looks, and what is it that the clinician tends to look at, and try and compare with the mannequin and the chest x-ray, and see how we try and make that correlation between what the patient is presenting with. I will try and give a global perspective as to what is it that we look for without trying to be definitive, and try and highlight some of the more common causes why a chest x-ray is done and what is it that we tend to look for. So at least you're aware that if your clinician orders a chest x-ray, he may not explain to you everything that he hopes to see, but trust him that at least he's looking for these things as he goes through his own initial evaluation of the x-ray, and he maybe just tell you that it looks normal, but you probably are not aware of the things he goes through before telling you that it looks normal. Let's, for instance, start with a patient who experiences the pain in the chest wall, and we did the chest x-ray. Obviously, all of us will know that the x-ray film was this way anteriorly. We shot the x-ray from the back. It penetrated the rib cage. It had penetrated the lungs. It penetrated the heart itself. It penetrated the chest wall. And then we came up with this film that shows something like this. Now, how do we relate this to that? Now, the soft tissue of the breast, obviously here, is going to be here. The rest of the rib cage, obviously the inside of the rib cage, we can see as it manifests itself coming off the thoracic spine all over these places. Definitely coming off the thoracic spine, we can see the shoulder joint as it's here. We can see the clavicle or the collarbone over here. That's the end part of the proximal portion of the shoulder joint itself with the scapula and the glenoid cavity. Definitely the rib, you can see the edges of the rib as it comes off. Obviously coming off from here is the 12th rib and coming backward. This is the lumbar spine. Obviously we're into the abdominal cavity with the gut and the end of the breast in a pendulous breast in this person. Now we into the chest cavity itself, haven't come through looking at when we remove the chest wall itself, and now the cause of the pain. Let's say that patient presented with chest pain localized to the chest wall. Then we're looking at saying, is the pain localized over the chest wall itself? Can I actually bring on the pain by pressing the chest wall itself, or this is something deep within? In the female, am I having chest over the breast area? Is there a particular area that I'm having the pain? Is it localized with a lump? In the young fella who has been playing sports or been involved in some physical activity, the trauma to the chest that's causing the shortness of breath, is it localized to the area where you were hit? And then definitely we examine the chest wall, making sure that the localized tenderness, and definitely ruling out evidence of a rib fracture. But what happens behind the rib is where the issues are. Let's say that person who now comes in with shortness of breath. Let's say shortness of breath, spontaneous onset, or maybe a history of asthma, and now comes with increasing shortness of breath. Whether it's mild shortness of breath, it makes you can wait a little while for mild shortness, but profound shortness of breath, definitely you worry whether or not there's any evidence to do with, especially in the absence of infection, whether or not there's any evidence to do with fluid, with air or fluid in terms of the pleural cavity. What is the pleural cavity? The pleural cavity, this is the inside lining of the chest wall. There's a pleural cavity, there's a sheet that lines the inside cavity of the chest wall, and there's a sheet that lines the outside cavity of the lungs. Between that space is this pleural space. When we do an X-ray for someone who comes in with shortness of breath, we're looking to see whether or not there's evidence of air or fluid within the pleural space. Well, how will that show up? That will show up with evidence of either increasing blackness that goes around it here, or increasing evidence of whiteness, which means that there's fluid accumulation. In the case of a pleural effusion, one of the more common causes of pleural effusion, especially when tuberculosis was much more common, it was obviously TB. In the cases that I'm seeing much more frequently, it's lung cancer that seems to produce much more of a pleural effusion in our society in the older adults. But in the X-ray, we've gone from what is the finding you find on the chest, the skin, the subcutaneous tissue, the chest wall itself, then behind the chest wall, the pleural cavity, the pleural space. But here again, that doesn't present with pain unless there's actually inflammation that causes cicatrization, or the lining between the inside lining of the lungs, the inside lining of the chest wall or the outside lining of the lungs actually stick together, and every time you take a big breath in, it can cause a tremendous amount of pain. The pain is because the pain fibers run under the rib in the neurovascular bundle. So every time you take a big breath in, the expansion of the rib cage causes that shooting kind of pain. So in the absence of trauma, someone with an inflammatory process can also develop that, even in the absence of an infection. An infection per se is a bronchitis involving the lungs itself, cause the outside lining of the lungs, can cause the sticking to the chest wall itself and cause that kind of shooting pain, especially in movement of the chest wall. But in the case of someone who presents, let's say, with a lung lesion, a lung cancer can also present, but even though it's a painless lesion, because the involvement of the rib cage or the inside lining of that rib cage and the outside lining of the lungs, the pleural space, you can get pain from the pain fibers over that area. But in addition to that, when you're looking at the X-ray, you find the lungs does not look good. It looks as if it has diffuse mottling, the whiteness around it. You can look around it and you see that it doesn't look normal. There's not this sharp margin where the cardiophrenic angle, where the diaphragm and the thoracic cavity meet, or the cardiothoracic angle that you basically look at and they're quite sharp. In a case of a lung that's becoming mottled, it looks abnormal. So even in the event of your physician looking at the x-ray, these are things that they go through in mentally in their minds as they look at the x-ray in order to come up, even in the presence of you presenting with a normal x-ray. These are some of the things that go through their minds before they even tell it to you. So it's not as if you look at it flippantly and say, oh, it looks good. You look at it, first of all, evaluating it from what you've been taught in medical school to what clinical acumen you've developed over the years, and you use that to actually evaluate that patient. So you're not telling that patient that the x-ray is normal from just looking at the film for the last 15 seconds, but what you've actually done over the years to say, well, I've done training over the years, and this is what, in my opinion. But sometimes it's difficult to go through each one of these steps to a patient and say. But I hope that basically, as we go through this, we can have a greater in-depth knowledge of what the clinician looks at, especially when we're trying to evaluate an x-ray, a chest x-ray. Thank you. We'll continue our discussion of chest x-ray and its usefulness. And I find in my practice it's one of the most commonly used tools, diagnostic tools. And in fact, more frequently with the advent of the workplace demanding that patients have a chest x-ray, especially with a positive PPD. I'll talk a little bit about the PPD and the chest x-ray, and there are sometimes the reasons for having the chest x-ray done and the duration and time to have it done. Positive PPD is when you actually do a diagnosis, an intradermal test, a skin test, to see whether or not that patient has actually been exposed to tuberculosis. The real importance of a positive PPD is if someone has been negative before and becomes positive, obviously to rule out whether or not that person is now infected. But if it's used for a diagnostic tool in terms of evaluating that person having pulmonary tuberculosis, then obviously you're looking for fever, hemoptysis or coughing up of blood or blood-tinged sputum, in addition to weight loss, anorexia, vague symptoms of malaise, and weakness. That's how classically a case of pulmonary tuberculosis. But this chronic coughing and hemoptysis and the weight loss and night sweats is probably the most common cause. Very much more common in the HIV population as well, and probably more prominence since the HIV outbreak 15 to 20 years ago. The issue with understanding the reason for a chest x-ray and a positive PPD is to make sure that we can treat those patients who are under the age of 35. It becomes mandatory to either put an isoniazid and B6 and vitamin B6 pyridoxine. The issue with the chest x-ray done and a serial set of chest x-rays done on a yearly or biannual basis is to make sure that person is not developing pulmonary tuberculosis. But even though it's a standard of care, it's probably not as beneficial to the patient. More important to tell them what are the symptoms of pulmonary tuberculosis and also to allay the anxiety associated with them thinking that they have tuberculosis. The positive PPD, you do a 0.1 cc's of the tuberculin test. Now that person develops a cell-mediated response, and that area over the dorsum, the ventral aspect of the left forearm where you've actually done the insert, you measure it, comes back to 5 to 10 millimeters. You know that is considered positive. Definitely over 10 is positive. But it doesn't mean that person has tuberculosis. It means they were exposed to tuberculosis. Now, the reason for getting worried is if your immune system, whether or not be from HIV or an autoimmune disease or cancer, the immune system decreases, then the chance of developing pulmonary TB is high. But for that young adult who is active and healthy and well, it means you've been exposed to it. Now, here is more of an issue. Is this exposure caused from the fact that you grew up in the Caribbean and you got BCG, Bacillus Camille-Guéret vaccine? No, it's not. That vaccine was discontinued, I think, almost 10 to 15 years ago. And even so, it only grants you a positive PPD within 5 years of having the vaccine. So to tell you that you got positive PPD because you got the BCG vaccine in your home country is really not accurate. We're probably more likely to have a positive PPD from riding the trains of New York City Transit than it is to get it from growing up in the Caribbean. And it's not said with any intent or malice or forethought. It's basically what the nature of it is. In closed environments, some of us, especially if we have a high incidence of people with autoimmune disease, and obviously in the trains we do have it. I cough on you, I inhale it, you cough on me, and you have a positive PPD, and you have symptoms of tuberculosis, especially if you're immunocompromised, and I inhale it, I definitely will get the bacteria, the Mycobacteria tuberculum. I will inhale it, but I do not develop the disease. My immune system mounts a response. I contain the disease, but I still develop the cell-mediated immunity. So my PPD became positive. I was exposed to tuberculosis. It doesn't mean I have tuberculosis. My chest X-ray will come out nice and good. But that's not a protection against saying that you will not develop tuberculosis later in life. The guidelines are very simple. If you're under the age of 35, to try and prevent that, we go on 9 months of isoniazid, which can cause a little bit of liver damage. That's why we bring you back every month to repeat, or every 2 to 3 months to repeat the liver function test. But what I don't want you to feel is that you're carrying tuberculosis as an infective disease, so you go home now and tell your family you've got tuberculosis. Tuberculosis is not an easy disease process. Tuberculosis in a person with immunocompromised state is a life-threatening illness. And it's not even treated with one anti-tubercular medication. It needs triple therapy. It is quadruple therapy at times. And a lot of these medications come with grave side effects. So saying that you have a positive PPD does not mean you have tuberculosis. But it means that you're exposed to it. Obviously, if I were exposed to tuberculosis, I would like the rest of the family inside of the household to be tested for tuberculosis. But to say that the two things that I find that are inaccurate is to say that you had a BCG, that's why you have a positive PPD. To say that you have a positive PPD means that you have tuberculosis is not true. To say that you have a positive PPD, that you should tell your kids, try and avoid exposure to people coughing in their faces, and try, if you have a cough, to cover your face and prevent the other person from getting it. Because you're not quite sure whether that cough is contaminated with another bacteria, which is contagious to that person, which is easily treated, or it is related to tuberculosis. So in terms of the common causes, the common reasons why we do x-rays in the young adults, PPD, a positive PPD, is one of them. And we're not expecting to find miraculous changes. The doctor will tell you your chest X-ray looks good, you're exposed to it. But do not go around saying that you have tuberculosis. Thank you. That's all for now. We'll continue our discussion on the usefulness of a chest X-ray. And it just reminded me about 24 hours ago, a patient who came in and asked me just to do an X-ray on his 11-year-old daughter, who basically had a positive PPD and was told by the school to have it done. I was seeing the child for the first time. We did an X-ray on the child as actually is the guidelines for a positive PPD. And lo and behold, I looked at the X-ray. The lung fields itself was perfect. Everything else looked nice and good. No evidence of pulmonary tuberculosis. Obviously, the child's alive, well, healthy-looking child moving around. I knew it was going to be negative. What I did not expect to find was evidence of a gross scoliosis involving the thoracolumbar spine. For the case of hypercompliance, I will not show her X-ray, but basically it showed evidence of a twisting of the spine. Here again is the usefulness of the tool that's being used, and also the closeness of the physician to a family, or being able to discuss things that are probably much more pertinent to that family. Here again, this person was a young father with 3 other kids, and has been told in the past by his daughter that she doesn't like the way her back looks, and he just looked at it and with the clothes on and never figured that there was anything wrong with her. So when we discussed the X-ray, I said to him, for the positive PPD, at least, there's no evidence of pulmonary tuberculosis, as we expect, because she has no symptoms. But what she has is something more debilitating than we're thinking of. She's got evidence of scoliosis, and quite a bad form of it. So my question to him was basically, didn't you or your wife ever examine your daughter when she's complaining of these back pains? Because they were saying that it was all due to carrying the heavy school bags and the books. In this child's case, what she had, scoliosis, which was when the thoracic spine, especially in a growing child, especially in young girls, the spine itself grows equally on both sides and we develop a very straight spine. In the case of this young woman, the one portion of the spine on the left side grew much more than the right side, so it started to develop a curvature. That curvature now makes the child have the center of gravity when she's carrying a school bag does not go through the pelvis itself, it goes through the hip itself, and she starts to develop hip pain and back pain. So you should pay attention to your kids when they especially tell you things about them. At least try and examine them. Because in this girl, you could actually, when you remove the clothes and just looking from the back, or ask her just to pull it, you can see evidence of this twisting of the spine that causes the scoliosis or the bending of that thoracic spine. In fact, she had thoracolumbar scoliosis, which means the thoracic spine, this part of it, plus the lumbar spine compensated for it. And basically now she has a kyphosis, which means the rib cage, which is held together, now is bulging out towards the one side to which they twisted. So the child would have told him in the past, I don't like how I look, but it's your duty as a parent to look at it before. And according to the father, she was complaining of this for almost about 1.5 years to 2 years. The good thing about it, there's not a surgery to recommend, but it needs to be monitored and see how it evolves. In fact, the treatment of choice at this stage will be to observe, and probably if the angle itself is in excess of the Conn's angle that is deemed necessary for that child at that age, then basically you use a Milwaukee brace at times. There's no need for surgery at this stage, but you need to monitor it. But more importantly for that child's self-esteem is to not think that he or she is deformed. And when I asked this young woman, she is afraid at all times even to go to gym because and wear the clothes of gym during the summer because of the bulging, the abnormal bulgings that is created because of the twisting of the spine that is basically very visible, and the fact that she cannot do the same activities as others. If you imagine that your spine is supposed to be a single straight structure right through with the thoracic cavity around it, when you move your arms, you're moving it symmetrically. In this young woman, it was tilted to one side, then compensated on the other side. When she shoots a ball, she's not shooting it from her shoulder joint itself, she is shooting it away from the back of the shoulder. So not only does she have a complex that she doesn't look normal like the others. When she wears a t-shirt, it shows the bulging of the spine. Not only that, she's not able to do the physical activity, so she's not even doing well at sports. Her self-esteem is low. And basically, this is something as a parent, when your child complains, at least the father or the mother, who is much more comfortable with that person, with that child, should be able to at least be interactive with them and bring it to the clinicians for evaluation. In this case, it was an incidental finding. That child is now being referred to the spine specialist for evaluation of and monitoring of that particular lesion. Now, the rest of the kids will also be monitored for that as well and make sure that they're okay. But my take on this whole thing was that this was someone who came in for one reason, but then you find that there was something else that's wrong in addition to that. So my advice as a physician for many years is that basically, when you're having something done, at least ask your physician, is there anything else that's wrong with the x-ray that you could discuss? In my case, I was happy. I was always interactive with the family. And it was easy for me to explain to the father, this is not your fault or your wife's fault. This is something that we should. It's a method of approach to our kids that basically we at least address the issues that they're having. And even if you're not comfortable addressing it, at least ask your doctor. Because I was only asked this question maybe about a week before, and I asked him to bring his daughter in on Saturday, and let's have a look at it. So what I'm saying to you as parents, pay attention to what your kids are saying, and if it's not relevant to you, maybe it's relevant to your clinician, even to discuss it. You discuss it, at least you get a viewpoint. If it's something much more serious, not only the child should be examined, or that person should be examined, but also, in fact, referred to another physician if, in fact, it's deemed necessary. That's all for now. In most of us who have been fortunate to be in the practice of medicine for at least 2 decades, we look upon the transition of the different levels of technology and still look back at the chest x-ray or the x-ray machine, especially the chest x-ray, has been one of the most useful tools that we've benefited throughout our careers and still continue to benefit from a chest x-ray. And sometimes we look at some of it, sometimes and say for many nights as a resident, as a medical student, as a resident, it has helped you to have at least some sleep when you could have had many sleepless nights. Sometimes you look back fondly and say, well, we didn't have an echocardiogram available at that time or immediate access to CAT scan or MRIs in every different hospital. But a chest X-ray, at least at that time, was a very, very good clinical tool to help in the diagnostic process. I remember going through neonatology and having to use, which is what you would be looking at in terms of newborns, and looking at what you need to get from a chest X-ray. That newborn child with shortness of breath that you have to put on a ventilator, you have to have a chest X-ray, you have to see the status of the lungs, you have to do your blood gases, you've got to follow serial X-rays, even a little kid being exposed to a tremendous amount of radiation in order to keep that child alive. Having put a CPAP on or put a child to breathe, you need to make sure that the tube is in the right place, because remember the caliber of those areas are so small, not even your little finger, that passing an endotracheal tube into it, you have to make sure that it's basically getting into the trachea itself, ventilating both lungs. If, for instance, you just go a little bit of like 1 centimeter over the bifurcation of the trachea, you get into one bronchus, you aerate this lungs, you overexpand it, and this lung collapses. Now you create a situation in your hand where that little newborn now dies or basically asphyxia because you've actually ventilated one lung and the other lung is collapsed. So a chest X-ray for us at that time meant a tremendous amount. Now with different levels of technology, things have changed a little bit. But it's still the onus is on the clinician to make that diagnosis and to be cognizant of the fact that the patient is the one who needs to be benefiting from the study, and you have to know what the study is going to be giving to you. You look into the young adult who comes to you with, let's say, running the emergency rooms over the years. You found that patients come in, well, probably had a couple of beers, not speaking fluently, probably speaking another language, and comes in and had a blunt trauma to the chest. What they did not tell you is that they also had an ice pick, very small ice pick, stabbed into them, but they think it's just superficial. So they have a little bit of a bruise on the chest wall. You examine that bruise, oh, what happened? I got a punch. But basically, you're not expecting that punch to be causing trauma to the rib cage, the pleural space. But that person was actually stabbed. In fact, I did have this happen to me before. The person was stabbed. Now, what was happening at the time is that the penetrating injury went through the chest wall into the pleural cavity. Now, when that patient breathes in, air is sucked into that hole. Now, the pleural space starts to expand. When the pleural space starts to expand, then just imagine what happens to this lung. The air is not coming not only from the trachea now, the air is coming from that stab wound that took place. And it's sometimes when you get a stab wound, it's such a small penetrating injury through the rib cage itself that basically it closes on itself. But every time you breathe in, the negative intrathoracic pressure causes the air to get into the pleural space. Now this lungs collapses. The lungs itself now collapses because of the increased pressure of the air. Now that not only is the air causing the pressure on the lung itself, is that the bleeding within the pleural space causes a hemothorax. Now that hemothorax causes that lungs to become compressed. Now the air also causes it to become compressed. Basic difference, this person is not, let's say for argument's sake, this person is not coherent enough, either from drinking or the factors having the effects that you're thinking, maybe they speak another language, or maybe because they're drinking, or maybe because they had a couple, they were smoking something else. And then you think that their state of lassitude or not coherent enough to you is as a result of what they've been doing, their habits of what they've been doing just before coming into the ER, not realizing at this stage that this person is being compromised, their cardiorespiratory system is being compromised because of their lungs being collapsed and not getting enough oxygen to the brain. An X-ray at that time, or clinical examination at that time, would reveal decreased air entry on that particular side of the lung. If you can actually have basal crepitations, you could also have evidence of egophony, where you hear the transmission of the songs of that person is breathing. But in an ER situation, emergency room situation with so much noise around, it's a difficult clinical diagnosis. Sometimes the easier thing to do is have that person lying on the couch, have an X-ray done on the couch, and you will see this as bright as day. When you look at it, is that the area in which the lungs is being collapsed, the lungs will start to have, you will start to have this blackness that appears here. The lung itself, when you penetrate it, will show up whiter because it's now being compressed. in the worst case of it, or as an advanced case, as it expands into the lungs, it pushes the entire mediastinum to one side and can also cause kinking of these great blood vessels if the entire lung fields itself were being pushed to one side because either fluid within the cavity, either blood within the cavity, or in terms of air compressing that lungs. So a chest x-ray at that time, and a lot of times I've been in the emergency room, has always been a savior to me in terms of making the diagnosis when I'm faced with a patient who I'm not able to communicate as effectively, especially I'm not quite sure that person was not the best kept person, didn't come with anyone else, brought in by an ambulance, and basically there's no history to be gotten from the patient because either the patient is drunk, seem to be out of it, and you're faced with making a diagnosis here, not ignoring the symptoms in front of you and not quite sure what it is. So in the past for us, from the days of neonates to the days of childhood illnesses, having a foreign body into the lungs, which causes the airway to be a child who swallows a coin, obstructing the airway, collapsing one lung, has always been a lifesaver at times. For the drunk who comes into the emergency room not coherent, who's had a stab wound, who's had collapse of the lungs, a chest x-ray at least at that time is an extremely useful tool, and it should be interpreted like that. In the next discussion, we'll try and see how the use of a chest x-ray takes place in the nursing homes or within a hospital situation to diagnose things like bronchitis, pneumonia, pulmonary edemas, pleural effusions, etc. That's all for now. Thank you. We've all have the benefit of having a chest x-ray done and know the usefulness of it. But not more frequently, especially when we're into an emergency room situation, having chest x-ray machines wheeled up and down. But the usefulness of it is to prevent unwanted deaths. I mentioned to you the previous discussion with things like pleural effusions, hemothorax, pneumothorax, which can cause a sudden death in patients who have had penetrating injury to the chest wall itself, or even for the person with chronic obstructive airway disease, the asthmatic, who develops a spontaneous pneumothorax, which is basically air within the pleural cavity, and that person is now dying because basically instead of the air getting into the lungs itself, it's getting into the pleural space. When it gets into the pleural space, then it causes the collapse of that lungs. So instead of you breathing through your mouth and getting air into the trachea, air is now being sucked in through either from the outside from a penetrating injury, which is what is going to cause the pneumothorax, or in the case of an asthmatic, from the fact of the pneumothorax being from bullous emphysema, which is the re-expanded lung, the alveoli, now ruptures, and that causes the air to get into the pleural space, and the lungs then collapses. A lot of times we're into the admission ward of the hospital and then wheeling x-rays, serial x-rays to be done, especially in the case of the person who's presenting with shortness of breath. Let's take, for instance, the average person who's been there admitted for, let's say, shortness of breath query cause. You're quite sure that it's definitely not cardiac, then you think it's pulmonary. That person now cannot breathe on their own, have an endotracheal tube. That tube is breathing for them with the help of assisted by the ventilation, but you have to make sure that that endotracheal tube is in the right position and not in a central position within the trachea and aerating both lungs to such an effect that they're getting the right amount of air into the lungs. Let's say in a case of a person who develops consolidation from bilateral pneumonia and are unable to breathe, or the HIV patient with pneumocystis pneumonia, who now has to be assisted to breathe. That person, as you expect the person to respond to the antibiotic, obviously you have to readjust at all times the amount of pressure you're putting into the lungs itself. Because as the infection resolves, the more pressure you can put into the lungs, you can actually cause bursting of the alveoli itself from too much pressure. So the serial x-rays are done at that time to see how much improvement is taking place, in addition to having your fingers stuck to get blood gases to see the partial pressure of oxygen. In addition to that, you also find that we do chest x-rays for patients who come in with trauma to the abdomen, in which in having abdominal distension. One of the more common causes you can see is air under the diaphragm from a ruptured viscus. Let's say there's air coming out from the gut, it will settle on the diaphragm. And a lot of the times, diagnosis of acute abdomen, totally apart from a chest finding, is made when you find there's air under the diaphragm itself from a ruptured viscus. I've seen a case in which over the last, 2 or 3 weeks, a patient with a perforated appendix who developed air, the only sign he had was localized pain to the right lower quadrant. But when the x-ray was done, the x-ray was done as as a test to see whether or not there was evidence of air fluid levels or whether or not there was evidence of an obstruction. Turned out he had a ruptured viscus because you saw this sliver of air under the hemidiaphragm. So that was not a case in which you needed to observe that patient. That patient needed to be opened up, had an exploratory laparotomy to find out exactly where the ruptured viscus was. That's by the way. But in addition to the fact we're faced with the x-rays being done for evaluation of patients who come in with shortness of breath, we think it's a bronchitis, but we know the radiological findings lag behind clinical findings. So it's not a replacement to have a patient you're monitoring for bilateral pneumonia when you know that the lungs are consolidated and that person's life depends on the fact of getting air in and out of the lungs. If you're seeing that the lungs are not re-expanding the way they should be, definitely your physical therapy, your antibiotics, your partial pressure of oxygen, your white blood cell count, these are things that have to be monitored very closely. But the chest x-rays wheel in and out of that patient's room, the relatives are told, move aside, let's take an x-ray. But the seriousness of the evaluation of these x-rays, especially comparing the x-rays, are very, very important. I'm not suggesting this a replacement for the clinical evaluation of your relatives or of that patient, but it is as important to monitor what the lung findings are doing, but also to remember that even if there are no changes, if the clinical impression is what matters most of all to the clinician, not the radiological findings. So and lots of times we see, and I see patients sometimes get angry that I've got to get another x-ray. Do I need another x-ray? It doesn't matter. It basically, if it's done to keep you alive, basically I think it is a very common tool, but it's obviously worth its weight in gold in terms of evaluation of lung conditions. I will discuss with you cardiac conditions in which we can benefit from having x-rays. Thank you. In addition to following the pulmonary pathology, lung pathology by x-rays, you also can actually make evaluations of cardiac conditions just based on x-rays. But we'll continue on the lungs, and especially when we see what it is, how the usefulness of an x-ray machine in the nursing homes. For us who have had relatives in nursing homes, a lot of times for the elderly patients who are lying there, sometimes just refusing to eat is an indication of an x-ray. Because this is how they're actually, one of the earliest symptoms of an infective process can present in an elderly. Depression being probably the most common, but an infective process, whether it be from the urinary tract infection from a catheter, or a bronchitis or bronchopneumonia presenting in an elderly. And in fact, you do an x-ray, you find that you have a relative with a collapsed portion of the lower portion of the lungs. Or you do an x-ray and you find there's evidence of pulmonary edema. I'm saying not that this should replace the clinician's finding, but we all as clinicians at any point in time, when you go to the nursing homes and you find that your elderly patient is not doing what they were doing the previous day, they're not sitting out of bed, they're not moving around, they're not looking as happy, you always wonder whether or not there's an infective process going on. And sometimes doing an x-ray is actually indicated. You do a white blood cell count, there's no evidence of infection. You may find out in terms of getting an x-ray done that a person's developing an infective process. There's no coughing, they have no strength to cough. There's no evidence of any fever. The immune system is not responding in terms of normal manner and producing a high-grade fever. So a lot of times they develop infective processes, whether it was from an infection or swallowing of a foreign body. Maybe they aspirated even on the food that they were taking. So a lot of times for us in the nursing homes situation, it helps tremendously by having an adjunct x-ray done to say, well, there's no pulmonary finding at this stage, so I'm happy at least the lungs are okay. Clinically, you can't ask them to breathe because they're not going to even cooperate with you in terms of breathing. Examining the lungs, you need air entry to make a diagnosis of evidence of basal crepitations, evidence of bronchi. You cannot just evaluate the lungs unless there's advanced disease or bronchospasms within an airway to actually allow it. You actually have to diagnose clinically by auscultation if you have air moving in and out, unless it's so obvious that the entire lung is filled with fluid that you get these basal crepitations and you're not hearing anything, or you get egophony, where there's difference in songs between levels of fluid, whether or not there's fluid below and air above, and you can actually make that diagnosis, but sometimes it's difficult. And a lot of times we depend on the chest x-ray to say, well, at least our parent, our grandparent, is not eating today, but at least the lungs look normal, the abdomen looks soft, the white blood cell count looks good. Can we say for today it's maybe that depression or maybe a withdrawal, maybe not feeling good about themselves, and try and work on that? But at least the physician is aware that at least the lungs are okay for the patient. The cardiac status we'll monitor in terms of our vital signs or EKG, make sure there was no cardiac event. We evaluate the abdomen by just palpation and basically find a nice soft abdomen with no evidence of wincing from the patient. So we know that patient who is not able to tell us everything that's going on with them, that we can at least monitor the more important status of those patients before assuming that we're just walking out with saying, well, the patient is just depressed today. At least we know for that day the cardiopulmonary system is intact. Let's try and see if there's any other things that develop over that period of time to assist us in at least recognizing early if that patient has suffered another event. Could it be cerebral? Could it be a mild stroke? Yes, it can be. But will the MRI show us any finding at that stage? Would it make a big difference to the patient's lifestyle? It probably will not. An infective process that can be treated and diagnosis evidence of a cardiopulmonary disorder, at least early o'clock, an X-ray can be a very useful diagnostic tool. So it's for us at all times to be cognizant of what it is to do clinically and in terms of examinations to at least assist in the management of our patients, whether it be from the neonatal services to the fact of getting a pediatric service of the patients, to the young adults, to the young adults who were physically active, to the young adults who involve themselves in smoking, etc., and for the elderly as well, and the young to middle age and the elderly, the spectrum of diseases that can actually be impacted upon by a chest X-ray, I think it's probably a wide cross-section. I hope we've managed to cover a few of these. It's no way extensive, but hopefully it's the common things that we see in our private practice. And I think in the next topic we'll try and elaborate a little bit more on some of the other ones that we see as well. That is all for now for the usefulness of chest X-rays in our family practice. Thank you.